Good afternoon, everyone, and I welcome you all to the 115th session of e-NISCHIT. And as you know, this is a platform where we work together and it's a collaboration to strengthen the activities between the HIV TB clinics. And it is with the platform where we learn. It's our endeavor, constant endeavor to learn every time and just learn from each other by the interactions and by the cases and the dietetics that we present. And it has been a very fruitful journey so far. And I'm Dr. Ananya Prabhu. I'm chair specialist at NITRD, and I welcome you all on the behalf of Dr. Jyoti from Share India, and from ECO we have logistics support from with Mr. Rakesh. I welcome you all to today's session. And today's session is going to be very interesting because today we are going to take up something which has not been taken up so far in the eco clinic. That is how to have a little surgical approach, how to learn a little about surgical approach, how to approach, when to know, when to defer that. Because every time we see something which is surgery related, we absolutely cannot make out anything because eyes don't see what mind doesn't know. So just a little bit of learning there so that we know that we should go on what right path to take as sitting at the ART center, sitting in the periphery. So that's why we thought that this session is important, that we get some little surgical insight. And for that, it's my pleasure to invite our expert today, Dr. Shaleen Prasad. He's the thoracic surgery specialist at our institute, National Institute of TB and Respiratory Diseases. Welcome, doctor. It's delightful to have you. And it's even more privileged for me because we have on our forum our ex-director and a stalwart and a person who needs no introduction in the field of thoracic surgery, Dr. Ravindra Kumar Devan sir. And he's one of the biggest names we have nationwide. So we are very privileged that you joined us today, sir. Thank you so much, sir.
Okay. Thank you so much for inviting me to say a few words. It is such a nice feeling to that a surgeon is joining this important session of e-NISCHIT. I think when HIV pandemic came, there was something called a scare among surgeons. Look, HIV is such a deadly disease. Why should surgeons? In fact, I remember meeting a Spanish surgeon who said, "Why should we subject ourselves and our families to risk for people's irresponsible behavior if we are touching them surgically?" There was so much scare about surgeons getting infected while working upon HIV patients. But that was in 80s, and in 90s for splenectomies, for idiopathic thrombocytopenic purpura and many other conditions, surgery became a routine in many patients who were suffering from HIV. And in our institution, as and when a case of pulmonary tuberculosis or tuberculosis from any part of the body which requires surgical intervention, it has never been denied for the precautions universally. But in the cases that we know, the cases to be HIV positive, we are doubly sure that we take our precautions universally, and no HIV patient should suffer or get denied any treatment which is possible in his or her case. With these few introductory words, I invite all of you to start your session with best wishes. Thank you.
Yes, sir. Thank you, sir. So one more thing I would like to add is that when we are sitting in the ART clinic and somebody says that he has TB and there's some infective etiology and surgery, then they, even as medical officers, they have this notion that all surgeon chuega. So, sir, it is so inspiring the work you have done, and it's an understatement to whatever we say about you, because it is the reality that people are not ready to touch HIV patients and start to surgery. So that's a reality we live with even now, even after 10 years of very good therapy, having that good therapy. That is a mindset even with doctors. So thank you so much, sir. I'm sure with whatever experience you share with us on this forum, we'll learn a lot. Thank you so much. So we'll start the agenda, with our agenda. So today's case is being presented by Dr. Arunachalam. He's a senior medical officer, ART Plus Centers at Salem, Tamil Nadu. I welcome you, Dr. Arunachalam.
Good afternoon to everyone. This HIV patient is registered in our ART center in 2006 November, and we have started an ART in 2007. Then after starting ART, patient's viral load suppressed, then CD4 also is good. Adherence is patients regularly adherent to the therapy. Then 2017 itself, we have started an IPT and completed 6 months of INS preventive therapy. In spite of that, patient developed a TB in the 2023 December. we have diagnosed in the private sector. It's a case of recurrent inguinal left inguinal abscess. It is trained by surgeon by third attempt only. They have sent the pus culture to the AIP culture. First time they think about it's a biogenic abscess, that simply give the IND and antibiotic, the patient again recurrence back. So then second time also they are repeating the same procedure and open laparotomy and doing the IND procedure as well as antibiotic. Third time they have sent they have searched for something. They have sent to AIB culture for the first they have sent the pus to the AIB culture. Then found out that it's a case of tuberculosis. Then we came to know that this patient is TB. Then ATT was started in the 2023 December. After starting ATT, patient is improving well. Total abscess is healed. The sinus also is healed well. This past history of TB is nothing. Then it's a case of recurrent inguinal abscess. Pus culture detected by the pus culture, AIP culture is found positive, but unfortunately we did not do the sensitivity test in the private sector. So based on available results, we can put on ATT. It's a regular dose ATT. CD4 count at the time of ART initiation is only 2012, but in the serial time it's improved well. Last serial CD4 count is around 832, 815, so more than around 800 CD4 is very good. Then viral load is target not detected in the even 2024 recently. So 2024 is target not detected, patients regularly at therapy. Diagnosed by only already I sent in the bus culture, AB bacillus pneumonia culture. But in this case, we have discussed the important point is it's a patients on regularly good adherence, good CD4 count, suppressed viral load, and then took IPT for the past 6 months. And everything's clear, but still they have developed their active tuberculosis in the inguinal region. That's why we want to share it in this forum.
Thank you for sharing. That's a very well worked up case. So, as I understand, the patient is on PLHIVs on regular ART. He got, when infected with ATT, he took ATT. He was not non-compliant on that. He was compliant with the treatment, and everything was well on that side. That there was no patient-related factor that we can pinpoint why he was having a recurrent infected pathologies. So your concern is that in spite of all that, in spite of giving regular ART, in spite of the patient being adherent, why the recurrent abscesses happen? And because a very simple answer would have been, oh, the patient is immunosuppressed. But right, as you rightly pointed out, his CD4 has been pretty good. It's been 815, so we cannot just put it as a back burner case. It's the HIV patient, so this is supposed to happen. No, he's been immunocompetent. So the same thing can happen in an immunocompetent also, or in an HIV whose CD4 is good. So it's a very similar scenario to that. So why you want to understand what and why of it, that why these abscesses happen in spite of the ATTs and in spite of patient being well controlled on other aspects.
So now I invite Dr. Shaleen for the didactics.
Abscess or cold abscess in HIV and tuberculosis patients and their managements. What is an abscess? An abscess is a localized collection of pus that occurs within the dermis and sometimes in subcutaneous plane, in the subcutaneous space, or in organs. They might be in any organ like your lungs, or in the brain, or in the liver, or in any other organ which they can occupy some space. They occur virtually anywhere in the body. Common locations otherwise are they happen in the groin, buttocks, axilla, and extremities. Now, there is a difference between the cold abscess and the normal abscesses, bacterial abscesses, what we see. Cold abscesses are not that much painful as the normal abscesses are. When cold abscesses are actually necrotic lymph nodes, they are mostly case-eating in tuberculosis disease. These lymph nodes are more prone to have concomitant bacterial infection in HIV. How do you diagnose a case of abscess? Most of the cutaneous abscess, the ones which are near the skin on the surface, can be diagnosed clinically on basis of physical examination alone. When you palpate the abscess, there might be tenderness, There will be fluctuation. Then fluctuation is the test for the amount of fluid which is there. To palpate both sides and you can feel the fluid inside. That is fluctuation test. And then of course there edema and induration also happens in an abscess. These are some classic characteristics of an abscess. Care must be taken to differentiate between cellulitis and abscess. That is one of the basic things that they ask a surgeon whether it is a cellulitis or an abscess. Then, in such a thing, actually, cellulitis resolves with antibiotic therapy without any drainage. But in abscess, we need to drain it. So, of course, there has to be a difference between whether it's an abscess or a cellulitis. In abscess, there will be fluctuation on examination. You can feel the fluid beneath the skin, and this is not the feature in cellulitis. In cases of equivocal clinical findings, some cellulitis later on they start developing into an abscess. So, if there is an equivocal clinical finding, ultrasonography can be used to assess the presence of an abscess. That is, they can assess the amount of volume of pus which is there inside, as well as they can see the size and the location, how much it is proximal or how close it is to any other vessel. Everything can be seen in the ultrasound. In further, if it is deep inside, CT thorax or CT abdomen may be also necessary to find out whether there is an abscess beneath and very deep inside. Now, what can be the possible contraindications to a bedside incision? Normally, whatever abscesses we have, we use local anesthesia and we can drain it out on the bedside. So, the most common contraindication is a pulsatile mass at the site of infection. A pulsatile mass it might be a hemangioma, it might be an aneurysm, it might be pulsatile because of that. So, and plus, of course, aneurysmal swellings which are infected, they look like abscess, but at times it might not be an abscess, it might be blood which is there below. Aneurysm is a sac of blood, basically, the vascular areas. So, and then the proximity to the vascular structures, nervous structures, they are also there. Like most of the abscesses which are there in the neck, they might be very much close to the carotid vessels which take the blood to the brain. So definitely when it is very close to the carotid vessels, while you are doing an IND that might injure the vessel, that might be a massive bleed, as well as there are nervous structures also which are involved most of the times. If there are some nerves which are going near the abscess, sometimes because of the infection also the nerves get damaged, sometimes because of the IND when they do the IND, and then when they put the forceps inside to break the loculi, in those cases also sometimes the nervous structures get damaged. So it is very essential to know where the nerves are, where the arteries are, where the major veins are. Then there might be a presence of a foreign body, or apart from that, the particular locations you cannot do an IND on that side. Like if it is an intra-abdominal or if it is an intrathoracic or in the brain, then the IND will not be possible. If it is deep, it will not be possible. Now, for the incision and drainage procedure for our abscesses, normally what requirement we have is we have to have all sterile equipment, which is like cleansing agents. We have to have iodine, or we can have hydrogen peroxide. These are good cleansing agents. Then we have local injectable anesthetic agent, 1% or 2% lidocaine with epinephrine. These are all used for anesthetizing the local area. And of course, sensitivity test should be done priorly so that the patient is not found to be sensitive to 5 to 10 ml syringe is used with there might be some 25 to 40 gauze needles required. If the pus is very thick, you will require a thicker needle to aspirate and see whether you can confirm whether it is there or not. If it's thin, maybe a small gauze needle will help. And then we need gauze pack. Gauze packs are required for cleaning up the pus. It is required to see the bleeding as well. And then we require a scalpel plate with a handle and a curved hemostat, normal saline solution with large syringe, and as well as if you want to take swabs for wound culture, that will be required, and scissors and tape for dressing. Arrangements prior to the procedure. The procedure need to be informed to the patient. What are we going to do? How the pus is going to come out? Patient's legal guardians must be obtained. Consent must be obtained, as well as risk of bleeding, pain, possible scar formation. That should be all discussed with the patient and attendants. The verification of tetanus patient status is also important step. The clinician performing the procedure should follow the usual precautions that include wearing a mask, gown, gloves, face mask, or goggles for protection. Although IND is not considered a sterile procedure, but it's always prudent to practice the sterile method. In operative procedure, we see that first we have to intubate using dignocaine prior to the procedure. Then we have to hold the scalpel and make a stab incision directly over the center of the abscess. Most of the abscesses have a yellow sinus opening from where little bit pus is already started to come out. So we can put the stab incision at that point and extend it both sides so that the pus is expressed completely. The incision should be made parallel to the skin tension lines in order to prevent scar tissue formation. Curved forceps can be used and is used for blunt dissection to further disrupt loculations within the infected cavity. And manually you can press it, or what we call it as expression can be used to facilitate the drainage as well. And after that, the post drainage dressing is a very important part. We have to, after the abscess has been drained, should be copiously irrigated with betadine solution, hydrogen peroxide, and sterile normal saline solution. The more we irrigate, the more the pus and everything comes out. Wound packing is not recommended for the abscess. Most of the abscesses which are small do not require wound packing at all, and it is not shown to have any good outcomes. And further, it contributes to the pain and obstruction in the vein of pus. So definitely better not to pack it unless and until we find that there is a significant amount of bleeding which is happening. So furthermore, packing has not shown to reduce any risk of abscess recurrence. It is always necessary that when we pack some bone with gauze pack, then the next day we can take it out and then we can do the copious irrigation with betadine solution and hydrogen peroxide one more time, and then we can see for any bleeds if are there. If it is not there, then we can put a gauze pack and let it wait from there. Local skin cleanliness is best for patients because most of the patients ask, "Sir, what should we do after the dressing has been done? Are we supposed to have bath? Are we not supposed to have bath? What should we do of the wound? Should the water go inside the wound? Will it be a problem if the water goes inside the wound?" The answer is that if you clean it with the water, the wound gets clean, the pus gets clean. It is good for the wound if you have bath with clean water every day. And while we are having bath, we should make sure that we wash the affected area properly. Post bathing, we should dry with a dry, clean cloth, and after that, we can further put any ointment or we can put a dressing on the top if it's still some pus is coming. So this is a photo in which you can see local anesthesia is being inserted at the point where the abscess is. So local anesthesia is inserted at both upper and lower levels so that there is complete in that. And then after we put a blade, there is a small incision which is we have made. From that, the draining out of pus is happening. We have drained out the pus. Actually, the photos are reverse photo. I think we should have been there because the gravity, the pus is going down actually, it not go up. But of course, there is a little error. We have to reverse the photo. And this is the scar you can see later on when after the IND, the scar has left. There always remains a small scar. Over time, in over 2, 3 years, 4 years, the scar becomes less and it gradually disappears. Thank you.
Thank you, Dr. Shaleen, for such an excellent presentation and giving us an overview of abscess. Basically, sir, the thing is that I think the main query is between the cold abscess and the. So,
May I add something here, Dr. Ananya?
yes, sir, please, sir. Please, sir.
Yes, for this audience, you see, most of us have seen that tubercular cold abscesses in the neck, lymph nodes, they are very, very frustrating problems. They keep on coming, you keep on giving drugs. And even the surgeons, the most important thing is that all of us have been taught that TB abscesses do not have to be drained. They should be anti-gravity aspiration has to be done. But by the time they become chronic and by the time they present to us, drainage is best. It is best that we do a drainage. Earlier it was taught that drainage should not be done because they will leave a sinus. But now with good anti-tubercular therapy, that's not a problem. And they slowly heal with the management and very good issues which Dr. Shaleen has raised. But I think 2 or 3 points which we should flag simultaneously. Number one, that just because it's a TB abscess in an HIV case, it doesn't mean that his or her treatment is any different. The treatment is same. Decision to operate, decision to drain the abscess, its regular dressing is absolutely same. But universal precautions have to be followed universally. So in HIV cases, we have a special HIV kit. You know, in the days of COVID pandemic, we had this. What was that kit? That was a special kit which became very, very famous. That's not the for HIV. We have a kit which is disposable, which should be worn by the surgeons and his team. He should put gloves, double gloves preferably, and he should also put a goggles on his face, as well as, if required, cover his face. And all the sharp instruments which are shifted between surgeon and the nurse, etc., they have to be done in a tray. They should never be held directly. So these are the precautions. They are universal precautions actually followed to be followed in all cases. But HIV, these precautions can be easily followed, and your results will be as good or as bad. And we have to see that after using these precautions, if at all there is a spill or some injury takes place, then a post exposure prophylaxis should be taken as has been recommended. So these are the things. In our institution, we have been doing it since 2000. We have done many abscess drainages, empyema drainage, surgical procedures in empyema, including decortications and 1 or 2 lobectomies also when they were indicated for bronchiectasis developing in HIV patients. There has been no problem to the staff. Of course, we get every patient's hepatitis B, hepatitis C, and HIV done preoperatively so that we know the status. That's all. Not to deny or accept the patient, and then take precautions more vigilantly. And those precautions should be used always. With this, and another thing which Dr. Shaleen has mentioned was cellulitis and abscess. Sometimes it is very difficult to differentiate when a cellulitis is becoming an abscess. So all those cases which if you are in between, you can treat them by some magnesium concentrated dressings. They absorb the moisture, and in addition antibiotics may work. And at a later stage you may aspirate, find a needle, and then do abscess drainage as Shaleen has very elaborately told. And I will also like to mention that empyema, gallbladder empyema, pericardial abscess, they are also abscesses, except that they are happening in an intrathoracic organ, inside in the visceral organ. So the cornerstone of surgical management of abscess is drainage, and drainage. So drainage you cannot avoid. Over. Thank you.
So the one thing that you have elaborated on is that the drainage now HIV TB patient with abscess now it has to be drained. That's a change in the mindset that we have to get. Okay, sir, because there's a lot of inhibition on that. So thank you for clarifying that point. I would like to know from Dr. Arunachalam if you have any doubts regarding the case.
So in this case, CD4 is good, adherence is good. We already discussed about immunocompetent individual HIV negative, immunocompetent TB. But in this case, it's IPT also given. IPT patient has taken a IPT for 6 months. Instead of IPT, patient developed a TB. That's why I want to share this case.
Patient was immunocompetent. His viral target not detected. CD4 was poor. Patient was adherent and compliant to the treatment.
Why recurrence?
And he has also been given the IPT.
Why recurrence?
Why the recurrence of TB has happened?
Sir, the recurrences happen because of necrotic lymph nodes. Most of the lymph nodes are necrotic because of tubercular disease. So there might be a site where there are multiple lymph nodes. One lymph node gets necrotic today, the other lymph node gets necrotic after 15 days. So definitely there have been many patients, like you can see in the photos which I have shown you, the person who has got two incisions, one here, one there. Two incisions in the sense that we have done IND 2 times, 3 times, because there were necrotic lymph nodes. The new necrotic lymph node which happened was recently. We have done the patient 3 times now for that patient, because new necrotic lymph nodes keep coming and we need to bring them out in a regular interval. It's not the same necrotic lymph node, the new necrotic lymph nodes keep coming. That is why there is a recurrence in the abscess. It is not the same spot, there are different lymph nodes which become necrotic at different times.
I would add that while drainage and abscess, adequate debridement should also be done. So preferably in some of the abscesses, because there can be a lot of muck present and necrotic tissue, some lymph nodes which are going to become necrotic in 2 or 3 days. So if possible, many of these abscesses should be taken up under general anesthesia, and then you can do a thorough job. That's why sometimes you get recurrences. If the surgeon is not able to do because of the circumstances the complete job under local anesthesia with a painful abscess, whatever local you may give, patient will have a considerable amount of pain. So better to do them as a planned procedure, and sometimes under general anesthesia or regional blocks, whichever are feasible.
At the cellulitis stage, the best we can do is the therapy only. And
Yes, yes,
and
antibiotic
anything
therapy.
that you think that they missed out by this recurrent abscess was anything that you think that was missed out from on the part of the RT center? Like they
No,
gave
they were-
but they can, is there any way they can do something preventive, because nothing that they just want to know okay, why it was happening, is there anything that they
That's because the lymph nodes keep getting necrotic. You can get an ultrasound done to assess which lymph nodes are what size. Accordingly, and CT scan also gives an idea of if there is a liquefaction in the lymph node. If the lymph nodes are liquefied, then that comes out in the CT scan. So you can see and you can assess. And as Dr. Diwan had told, we can plan it in a general anesthesia procedure. In local anesthesia, most of the patients, they do not allow you to do further deep dissections because of the pain. Surface, you can put an incision, you can drain out the pus. That will not be a problem for them. But once you start putting your curved artery forceps inside and try to dig out some lymph node, he will have pain, she will have pain. They will not allow that. So in those cases, definitely, as Dr. Diwan had told, we need to give GA. And in general anesthesia, definitely we can dissect and see out all the lymph nodes are there intraoperatively. Or priorly we can get a CT scan done, and then we can see for the liquefied part which is liquefied, which are the ones which are necrotic, and then accordingly plan.
Okay. And cellulitis, like general care, what the patient should do, like clean the area to prevent it from getting an abscess.
Ma'am, actually, most of the cellulitis patients need antibiotic recovery, and antibiotic is good for recovery. But in the cellulitis patients, most of the
Like
times,
said, magnesium.
yes, we have to use something like called as sumac dressing, or as sir I told, magnesium products. They are good in absorbing, and they sometimes they help in relieving the swelling. And apart from that, venous congestion does take place. So in venous congestion, raising the limb, or sometimes it helps in reducing the swelling. And although it doesn't help in diabetes, the cellulitis part is improved only by antibiotics.
And anti-inflammatory is also.
Anti-inflammatory and as well as antibiotics.
Oh.
Dr. Arunachalam, can I ask one question? When you have given the IPT to the patient?
2017, ma'am. December 2017 to June 2018.
Okay, in 18. So generally we say, sir, that if we give the IPT to the patient, it gives 66% around the protection from the TB and the efficacy, though it is not yet proven. We do not have that much of evidence. But about six years it gives protection. But he falls sick in 2014. He had given the IPT in 18 and he got contracted with the TB in 2023. So there were only 4-5 years.
So what's your experience? Do you give IPT or?
Actually, compromised state is a different issue, but tuberculosis is so common. When and where we get it, we do not know. It might be some concomitant infection from some other person in the neighborhood.
So IPT, do you subscribe to it, or that some patients you give IPT to patients, and that's what she wants
that
to
is
know.
the part of the physician.
Have you ever taken the history of the patient, those who you have done the surgeries? Have they ever taken the IPT also? Are they?
And the surgeries which I have done it previously last 5 years. Those there were 3-4 HIV patients where I had operated, and they had post-operatively they had very good recovery.
Yeah.
The ARTs were going on, ART treatment was going on, and post-op recovery was very nice. There was no case of any complications like
So what cases surgery you have done? What HIV?
Tuberculosis and decortification.
Tuberculosis only?
Yes.
Okay, tuberculosis like said empyema and
Yes,
that's also a big problem.
Decortications are required in most of the empyema patients where the lung is quite good. So, and plus, if it is lobectomy, the lobectomies happen in tubercular patients where the tuberculosis already happened and it has been cured. After the disease has been cured, the lung which is having the disease, the cavity areas of the lung, they keep bleeding. So for that, we set. So that's a very good start.
Since we in current scenario, so we are getting the IPT and now the TPT to other non-HIV patients also. So I just have a question कि जिन लोगों ने पहले IPT ली उन लोगों में TB होने के इस तरह का जो सर्जरी की जरूरत पड़े तो ऐसे कितने
Tuberculosis can happen. Tuberculosis can happen anywhere. India is a country where we have lot of people. So definitely exposure, when it happened, how it happened. If a normal man can get, definitely a person who has got HIV can also get the same.
So we can say that IPT gives you more protection up to 60 or 70%, but it does not give you protection 100%. So there are always chances. Yeah, there are many other factors.
Nutrition.
Yes, yes.
Those abscesses. And so like this, there is a cold abscess, there's a tubercular abscess. But even in tubercular abscess, they can be bacterial abscess, other bacterial abscess.
Yes, yes.
So can you tell us about that? Like, would that be? Like we will keep giving him ATT only. So when do you think that we should be giving antibiotics?
Ma'am, antibiotics will depend on your pus culture sensitivity.
Okay, so that's the bottom line. That you have to say
all depend on pus culture sensitivity. And if it comes as sensitive to particular antibiotics and particular bacteria is there, accordingly we have to give. Sometimes we get fungal also. So we need to sometimes send fungal cultures also. And
so, sir, what is the time for the referral? Because since the patients are coming to the ART centers, so what is that period when the doctor should refer that patient for the surgical?
As soon as you see an abscess. As soon as
you should not wait for the results of the antibiotics and all.
No, actually, abscess is a collection where pus is already there. So when the pus is there inside, it is in the avascular area. It needs to be drained out at any cost. That needs to be drained out. It will not disappear. If the pus is there, it will not disappear. Whereas in other cases, what happens is that it spreads and it becomes more bigger. And in spite of the antibiotic coverage, it doesn't heal. So definitely to be needed.
So, Dr. Arunachalam, are your questions answered now?
Yes, ma'am. It's thing is IPT is not protected for 100%, as you said. Then how long it will be protected? Once the patients complete 6 months of IPT, it's effective for up to 5 years or 6 years.
Generally, they say 5 years, but it's like with the trial, most of the trials have been done on PTB. So EPTB and HIV is a different ball game or different case. अलग ही case हो जाता है EPTB. तो ज़्यादा common होती है जैसे कि हम जानते हैं HIV में. पर हाँ 5 years तक बोलते हैं कि 33 to 65% तक protection होती है. But you cannot predict because as they said that environmental factors are very important.
Maybe nutritional factors, maybe other factors. So,
Okay.
exposure, recurrent exposure. Many scenarios we have to see.
Reactivation भी हो जाता है.
Reactivation of disease. Tuberculosis. There are many reasons for it.
और कोई आपका और किसी तरह का कोई सर्जिकल क्वेश्चन हो इन HIV TB तो आप पूछ सकते हैं.
So we have one question. What we supposed to do if new abscess or big lymph node appears after 5 or 6 months of continuous phase? Do we need to repeat IP again?
First things first, we need to get an ultrasound done and assess the abscess, volume of the abscess, whether it needs to be filled out. If it is quite big, it could be done.
So we need to do the intervention along with the therapy what is being continued.
Like sir was saying that bone abscesses are also very common. So how calcium supplements, sir?
Vitamin D, calcium supplement for that. You will find that the patients who have had abscesses, bony problems, or bony abscess, they are the people who are not having calcium in their nutrition. Most of the common sources of calcium, like milk, it is a very big problem. They think that if they have milk, they will have more pus. That is one very big problem. So it is on the contrary, people who don't have milk, they have low calcium deficiencies. They are more prone to pus kind. So that is the common thing I have found. There has to be a link which has to be found within them. But this is what I have found.
So here the questions are. So our first question was, what can be the complication of abscess drainage by incision? The options are cellulitis, bleeding, vomiting, and breathing difficulty. So the correct answer for the question is option B, bleeding. And the next question was, the classic characteristics of an abscess are erythema and induration, B, tenderness to palpitation, C, fatuous, and D, all above. So the correct answer to the question is all above.
For giving us the answers. So, because it has been a very technical session. So basically, हम जैसे abscess drainage हो, कोई छोटा मोटा setup हो, तो sinus जैसे डर लगता है, पेरिफेरी में sinus बनने से. So should some medical officer attempt himself to do the abscess
Actually,
drainage?
most of the sinus happen because of
ART center पे we do not have such setup now.
most of the abscesses happened, as Dr. Divana told. Most of the abscesses happen because there is a necrotic lymph node which is slowly necrotizing, and it really there is a pus output from that. So that definitely when after the incision has been given and the incision closes, there is a small.
आजकल आप जानते हैं कि पेरिफेरी में लोग YouTube से सीखकर और पेशेंट के बेनिफिट के लिए कि भाई उसको पेन हो रहा है बहुत, कहाँ सर्जरी है, पेशेंट कैंसल रिक्वेस्ट, तो आपको तब भी would you advocate that कि मतलब abscess drainage कर लें?
But abscess drainage can be done only in a medical center.
है ना?
It can be done only in a medical
It
center.
can have negative.
You cannot do a abscess in a center where there is no medical supply or no medical support. We need at least minimum support, a minor OT, a small OT. It is a minimum requirement.
At this point, it is important to mention because in connection with TB, most cold abscesses occur in neck. So number one, when you are doing an incision in the neck, and because there are major vessels nearby, carotid artery, and as he mentioned correctly, some of them can be an aneurysm, carotid artery aneurysm, and you open it, you will lose the patient on table. So, and you have to keep a sufficient distance from trachea also. You know your anatomy very well, and you can do as much. So that's why I say sometimes if you suspect there are multiple lymph nodes involved, there is a deep sinus, etc., you should plan it under general anesthesia in a safe setting. And this procedure, abscess drainage, should not, just because it's a small procedure, should not be taken lightly. Even under local anesthesia, I remember a case where a child, an abscess was being drained. He went into cardiac arrest at the same time, and we had to rush in and save the situation because of the sheer shock of the pain itself. Patients can go into cardiac arrest. So that is also, though these procedures should not be taken lightly. Just because they are small procedures should not be taken lightly. Every surgical procedure deserves respect, should be planned well, and to be done in a deliberate manner.
Yes, sir. Totally agree to that. That's why I wanted to send a strong message across ART centers, because I've been getting such queries that the abscess patient is saying, please, आप यहीं पे train कर दे तो क्या कर दे? But yes, as you said, we're not very sure that it's an abscess. It can be lying very close to a very vital structure.
Ultrasound and HRC can it will give a clear view of abscess or cellulitis. Or if there are any other structures nearby, just very proximal, there might be a situation where you find that the pus is eroding into the vessels. There might be erosion of the vessels. So definitely, if you open up, then there will be a massive bleed at that time. So erosions have to be seen. All these things, assessment is only via the CT scan or any other ultrasound which can be done prior to the visit.
Yes, totally. So, because I would like to request Dr. Devan sir, because has this 360-degree report, because he knows it from the tuberculosis side also and from the surgery side also. So any final word that you would like to say to people who are just seeing patients with TB, HIV at the periphery?
I think I have been butting in regularly, but I think what I have already said, number one, the abscess should not be taken as a small procedure. It deserves respect, and all planning and deliberation should be done. And patients, especially in cold abscesses, have to be dressed for a longer period, sometimes 2 to 3 weeks after that, because cold abscesses take longer time to heal than a normal hot abscess. And occasionally, as from my experience and Dr. Jain's experience, we realize that those sinuses which are persisting and becoming almost very difficult to treat even after surgery, there used to be something called this fish oil dressings, 7 C's fish oil. We occasionally tried that, and that has also led to success. Persistent dressing with fish oil, because vitamin D used to have some role in persistence of a tuberculosis infection. That is something called of a something which we in the pre-chemotherapeutic era, these techniques were developed, how to deal with cold abscesses. They are occasionally relevant even still. So, and sometimes you see neck abscess can actually have an intrathoracic extension. That is why CT scan is very important. They come in and then they have to be dealt with properly in front of thoracotomy, and you have to plan. And otherwise, it's not that one should be scared of abscesses. I think in a peripheral setup, you can put in a needle and see if it is an abscess, and then take a surgeon's opinion. That can be done easily. Okay, thank you.
Thank you so much.
So I think Dr. Devan for his motivating words and the final words of the sessions. So I'm sure that our ART participants would definitely take message for how to manage such cases at the ART centers and what is the point of referral to the surgery or taking a surgical opinion. I thank Dr. Shaleen for his didactic and such a good presentation. I thank Dr. Arunachalam to bring out such a case which we can discuss at this forum. And I'm sure that our participant might have developed some insight to manage such cases at the ART center, and they have insight when they have to refer the case. So I thank Dr. Ananya to moderate the case in a beautiful manner, and we had such a good discussion. And lastly, we have one question, so I would like to ask sir, can we prolong ATT in such cases?
Prolonging the ATT will solely depend on what lymph node biopsies you have sent, or what the pus or whatever CBNAT or MGIT report comes. What is that symptomatically, how the patient is feeling now, how many days ATT he has already taken or she has already taken. Has he completed the course of ATT already? And plus, of course, we have to see the sensitivity of the ATT, what you are giving, whether it is still rifampicin sensitive or resistant. That is very important.
I thank all our participants who have joined today, and I request you all to give us the feedback. The link has been sent in the chat box. So the session will be on for some time after this session is over. So I request you to please give us the feedback. Thank you. Thank you, everyone.